updates in cardiology. I would like to express our gratitude to our respected well-known speaker, Dr. Anand Shukla Sahib and Dr. Tarun Madan Sahib for joining us. We feel privileged to have a successful doctors. Now I would like to invite Dr. Dhiren sir, our Joint Secretary, to say few words about our College of GP. Over to you, Dr. Dhiren sir.
Thank you, Dr. Smitaben. Good afternoon to each and everyone. College of GP is a unit of IEMA headquarter, and it is having all the branches, many branches in all the states, and they are carrying so many scientific programs throughout the India. IEMA headquarter is also conducting this different certificate courses for all the family physicians of the different faculty, different specialities. So anyone can join through, and they can have a certificate for that. We also at GSB level, we have conducted so many scientific programs, and this is our 8th program on online webinar. It is very useful for each our family physician pertaining to our family practice. So it is very useful, and anyone IEMA eligible doctor can become the member of College of GP, GSP and IEMA both the way. So with the short discussion, I will like to invite Dr. Leon for the progress of the product. Thank you.
Sir, at present we have in Gujarat at College of GPS strength of 2,100 and plus.
Thank you, Dr. Dhiren sir.
Sir,
Now
1 minute.
I would like to invite Dr. Leo.
1 minute.
Yes, sir. Please go. Please
we are also planning the program in the next month also in this chain. And on the 19th of May, we have a very big program of it may be the hybrid type of physical as well as the online. So all are requested to join in this program, be a part of that program also. Thank you so much.
Thank you, Dr. Smitaben. Thank you, Dr. Dhiren. And thank you, Dr. Jaswantji, for making this possible. Also, I'm very grateful to all our speakers. Hope I am audible. Can you hear my audible?
Yeah.
Yes, sir.
I'm grateful to both our speakers. Okay, Dr. Anand and Dr. Tarun for being with us here today. All these eminent speakers have added a great aura to this show as well as the CME, and we welcome them. We are thankful to them for giving us this precious and very valuable time. Welcome all the other people, all the other doctors who are online right now. Welcome to this scientific session. And without much ado, I would like to introduce Dr. Tarun first, because he's ready with his PPT. Dr. Tarun is he's an MD physician as well as DNB in 2 branches, medicine as well as cardiology, and has been practicing for the last 16 years. So he's a very, not only an eminent and academic person, but also a very experienced person. And he specializes in interventional cardiology as well as peripheral vascular interventions. He is now attached to Star Hospital. And without much ado, I would welcome Dr. Tarun to please go ahead with his presentation, because he has a time limit of just 20 minutes as per our schedules.
Anand sir, you are sharing the screen first?
I would request Dr. Tarun, because he's ready with his PPT. Just a little bit.
I think both the speaker has got the screen ready.
Dr. Tarun,
Sure.
you can go ahead.
Yeah, sure, sir.
Same, Dr. Anand can also prepare his technicalities.
Sure, sir.
I request everybody else to get muted. Even I'm going to mute myself so that we don't have any background noise.
My slides are visible? Hello, sir.
Yes.
Am I audible?
Yes. Visual as well audible. Both.
So I will be presenting about various endovascular interventions available for peripheral vascular disease. Slides are visible?
Yes, yes, sir.
So there are many arterial interventions and venous interventions throughout the body. We start from the top and we can go till the foot point where the different diseases are there, and we can do interventions. Starting from the upper limb, lower limb, aorta, renal arteries, mesenteric arteries, carotid arteries, and below the knee arteries. A very common disease in which there is a hypertension called coarctation of aorta. A young male who presents with very high blood pressure, you can see the thoracic aorta is very much narrowed, and with the help of stent, we have relieved the blood pressure and we have avoided a major surgery. This patient clinically presents with feeble pulse in the lower limb and very high
Slides
blood.
are not moving. Dr. Madan, slides are not moving.
Now it is seen.
Yes.
No.
The slide
Slide is not seen, sir.
not seen. I can see in my.
Sir, visible.
First slide, arterial intervention
Slides
is
are
seen, sir.
Visible.
Visible or not visible?
Sir,
Visible.
visible.
Shall I go ahead?
Yeah, yes, sir. Of course.
So after doing the stent, there was zero gradient and there is no scar on the body of the patient. There is no blood loss. And as we can see, the stent has been deployed in the thoracic aorta and the patient is doing well. This is another case of coarctation of aorta, which was relieved with the help of balloon dilatation. Now coming to a very grave disease, which is called gangrene in the lower limb. The patient presents to us with claudication or the severe pain or non-healing ulcer.
Yeah, Tarun, your slide is not moving. Only one slide we can appreciate.
Dushil, are you there? Dushil? Who is there in the technical side?
Hello, sir. I'm Rahul.
So you can
Now
just
it
write
is
it.
visible. Now it is visible.
Is this seen now?
Yes, yes.
Now
Yes,
it is seen, sir.
Yes, now
It
it
is
is
seen,
seen.
but the problem was what is changing.
Now it is seen.
Now it's okay. Now
Yeah.
it's okay. Yeah.
So this is a non-healing ulcer in the medial part of the ankle. And what we can do, we can relieve the claudication by doing some intervention. We can relieve the rest pain. We can prevent the amputation. We can change the level of amputation from above the knee to below the knee and from below the knee to just a transmetatarsal foot amputation. Ulcer healing can be made very faster because the blood supply is reaching now to the foot. Resting pain is received. This is a patient who has aorta which is totally occluded. The iliac artery is not getting any flow from any side. And both the sides we have done stenting by doing just a small puncture in the femoral artery. And after this, the patient walking has improved. And because of the improved blood supply to the penile area, his sexual erectile dysfunction also gets better. So these advantages are there with the help of endovascular intervention. Another female, which was 90-year-old with a total occlusion of the aorta, and this was the healing very poor in the lower part of the leg. And this patient received a stent. And then after putting a stent, we can see the good flow was given to both the iliac arteries and the patient was doing well. Now, there are different presentations of these patients, but ultimately without surgery, just a small puncture in the femoral artery on the brachial artery, we can relieve their symptoms. Coming to another case, which is aortoarteritis. Young female which present with pulseless disease. This patient had a thoracic aorta which was critically narrowed, and we did a balloon angioplasty, and after that we put a stent, and she conceived after this procedure and gave birth to two children. And this patient was left common iliac artery which was totally occluded. This was the pre-result. You can see on both the sides the iliac arteries are not seen, and this is after putting the stents. You can see very nice flow to the both groin, and the patient is walking normal. Coming to the neurological part, carotid and subclavian artery, which cases should be addressed to? Those who present with paralysis, those who have suffered a cerebrovascular attack, those who are having syncope, and every physician should get their carotid Doppler done. And after the carotid Doppler, we should subject them to CT angiography and then DSA, which is invasive angiography. And then we can do carotid artery angioplasty. So the first picture is showing a very critical narrowing. The arrow is marked very critical stenosis of the left carotid artery. And the second picture is showing a filter which is placed in the carotid artery to prevent the emboli going to the brain. And the third picture is showing a very nicely deployed stent and the carotid artery is normally flowing. This is a animation which shows how the filter is deployed. And once the filter is deployed, this filter helps prevent the embolization going to the brain. And you can see in the yellow part, there is a stenosis. There we do a balloon angioplasty and followed by the stent deployment. This stent is getting deployed and this stent will be post-dilated and the carotid artery will be opened up nicely. And in this process, whatever emboli goes distally, the filter captures them. And after the completion of the procedure, the filter is removed. You can see RBCs in the form of emboli are getting captured by this filter. And later on, this filter will be removed and the stent will remain in place. So the patient can be protected from repeat stroke. Patient can be protected from further complications. So this is another 65-year-old female. Arrow is showing in the neck part, there is critical narrowing of the carotid artery. And after doing balloon angioplasty, this was disappeared. Now, same aortoarteritis, which involves the thoracic aorta, can involve the carotid artery. So every block is not atherosclerosis. Sometimes it is because of the inflammation of the vascular tree, which is called arteritis or vasculopathy. And in these patients, if we give a good flow to the brain, the second picture shows the circle of Willis, which we have studied in the anatomy class, that both the carotid arteries are supplying the brain circle with the circle of Willis getting good supply. So this second patient of aortoarteritis had right subclavian artery, which was totally occluded. Along the clavicle, you can see there was no flow, and after the balloon angioplasty, the flow was improved. And this patient, the syncope also gets better now. The patient was complaining of loss of consciousness, and there was no reason available, but by doing the angioplasty, the syncope and the symptoms gone away. This procedure can be done by brachial access or the femoral access. And this patient had a left subclavian artery, you can see totally occluded. And after putting a stent, the vertebral artery also got the antegrade good flow, and we can prevent the steal phenomena. In the left subclavian, steal can be prevented and the arm blood pressure also becomes normal. Now coming to below the thoracic part, there are multiple gastric problems in which there is a celiac artery, superior mesenteric artery, or the inferior mesenteric artery stenosis is there because of the tobacco chewing. These patients present with loss of weight, cytophobia means the food site makes them go away from there, and anorexia because whenever they eat food, there is a lot of pain in the abdomen. The second picture shows the stent being deployed in the celiac artery, and the celiac artery flow was given very nice after the stent, and the patient was able to have full meals. The second patient shows the celiac artery was totally occluded, and the superior mesenteric artery was totally occluded. And now you can see there are two stents, one in the celiac artery and one in the superior mesenteric artery, and patient is doing very well. So these patients who are chronic mesenteric ischemia can be benefited by doing these stenting procedures. This is a CT scan in the follow-up which shows that the celiac stent and superior mesenteric stents are doing very well. Coming to a very rare disorder of renal artery stenosis, in which there is resistant hypertension because of the less blood flow to the renal artery, because this increases the renin hormone level. So by doing a femoral angioplasty, then you can put a stent in the renal artery and prevent the renal failure. When we should suspect renal artery? Whenever there is a high blood pressure, whenever there is a pulmonary edema. All these patients should be sent to radiologist for Doppler examination, and Doppler will show renal artery stenosis. After that, we get a CT angio or invasive angio in the cath lab, and then we can plan for stenting. This was a young female with right renal artery stenosis. You can see the proximal part of the renal artery is critically narrowed, and after putting a stent, this patient was doing well. This was a very interesting case of male patient with creatinine of 12 milligram. He was almost at the verge of going for a renal transplant. The CT angio was showing right renal artery and left renal artery, both 100% occluded. And we took this patient for angioplasty. Right renal and left renal angioplasty was done. And after 12 days of aggressive therapy, he was discharged on a creatinine of 1.2. So we saved one renal transplant in this young gentleman. And whenever we do stenting of these patients, they come back. If they stop the medications, the stent also get occluded. And again, we do angioplasty of the occluded stent and we increase the blood supply to the kidney. Now, a very rare urological vascular interventions. A lot of people for renal stones are undergoing PCNL procedure, percutaneous nephrolithotomy. So radiologist, urologist will put a pigtail, which is a DJ stent, and do the PCNL procedure. And after the PCNL procedure, sometimes patient is complaining of hematuria, persistent blood in the urine. If we do an angiography, we find because of the PCNL procedure, there is aneurysm formation in the kidney, and we can do embolization by putting the coil, and we can stop the oozing from there. Coming to below the kidney, abdominal aortic aneurysm. The first picture shows a normal abdominal aorta, and the second picture shows a large aneurysm of the abdominal aorta, which can rupture if it is not treated. So nowadays, without open surgery, we can do percutaneous aneurysm repair, which is called EVAR procedure or TVAR procedure. We can put stent in the abdominal aorta, and then these stents can be deployed in a pajama fashion. One stent to the right iliac artery, one to the left iliac artery. There is no general anesthesia. There is no laparotomy. Covered stents are deployed, and there is no blood loss.
Deployed. At this time, the stent graft.
So this is a patient who had
Continue withdrawing the graft cover.
thoracic aortic disease.
Deploy. Anytime. Pull back the trigger to more rapidly deploy the stent graft. When trigger is first pulled back, place proximal hand on screw gear.
So by deploying this stent graft, we can finish the procedure in a thoracic aorta as well as abdominal aorta. Inferior vena cava occlusion. Coming to the DVT part, venous intervention. This patient had abdominal distension, and we can see the inferior vena cava was totally occluded. This patient had large ascites, and we did balloon angioplasty of the IVC and then deployed a stent in the inferior vena cava at the junction of right atrium. And this patient did very well. Ascites was also disappeared, and the patient received a very simple medication in the form of warfarin, which is an anticoagulant. This patient has a large thoracic aneurysm, and without open surgery was subjected to stenting, and this is after the stent graft in the thoracic aorta. Another patient who presented with hemoptysis. There was a ruptured aneurysm in the left subclavian artery, which was treated with the help of a covered stent. Now, what are covered stents? Covered stents are normal stent with the help of a membrane which is over the stent, which prevents the leakage, and the patient can be benefited. DVT, deep vein thrombosis, we all of us see very commonly that the femoral vein or the iliac vein gets occluded. We take this patient in cath lab. Openly, we do the popliteal vein puncture in the ultrasound guidance, and we suck out the clots like this. A patient is lying down in prone position, and there is a catheter in the popliteal vein. From there, we will infuse the urokinase or streptokinase, and this patient will benefit. Now, this is how the fountain catheter is placed inside. A patient is lying in the table, and we have punctured the popliteal vein. Patient is fully awake, and through the popliteal vein, a wire goes inside, and then we do the angiography. And after the angiography, we suck out the clots, and once the clots are out, we infuse the drug. Sometimes during the procedures, like nephrologists are putting central lines, and some radiologists are also doing central lines, anesthetists are putting central lines. These central lines sometimes they break and they go inside the cardiac structures. So this is a broken catheter, which was femoral venous catheterization in a obstructive uropathy patient. The line was broken inside, and without doing a laparotomy, we percutaneously retrieved the line, broken catheter from the body. And this is how we remove the catheter by the help of snares. We catch the foreign body, and without any laparotomy or major surgery, we can remove the foreign body if it is gone inside by mistake from the body. So what are the advantages of endovascular therapy, sir? There is no scar. It is possible in local anesthesia. There is no blood transfusion. Early mobilization of the patient and early discharge of the patient is done. Thank you, sir.
Thank you, Dr. Tarun, for your valuable insights on the subject and your lovely real-time videos. And this, these stents breaking inside and, your snares, it's the first time that I was visualizing. We haven't seen that before. We've been through a lot of these, interventional procedures and CMEs, but this is something that has never been talked about. So
Yes.
thank you very much
Thank you, sir.
for your valuable and scientific presentation. We'll take the questions a little later, but first I would like to introduce Dr. Anand Shukla. Dr. Anand Shukla is a very, very experienced physician. He is MD and DM Cardiology, has been working since 2005. That's a long time. And his areas of interest are complex coronary interventions, rotabulations, CTO interventions, post-bypass. That's very interesting. Coronary imaging and physiology. And Dr. Anand's topics will be CT coronary calcium scores, CT coronary angiography, and obviously conventional coronary angiography. We are very, very interested in this subject of calcium scores, doctor. So over to you without much ado and fuss. We welcome you to this presentation, and we look forward to your experience on the subject. Go ahead, doctor. Just since he's getting ready, doctor has done his DM from SGPI Lucknow, and he's also a professor. I forgot to tell you, he's a professor at UN Medical College and Institute of Cardiology, Ahmedabad. He's also attached to HCG and Krish specialty centers. Are you there, Dr. Anand? Hello? Dr. Anand?
Anand bhai, unmute, please.
Can you see my slide?
Sir, unmute.
We can see your slides, Dr. Anand. Welcome.
So should
Yeah, please go ahead.
Rahul, unmute kar rahe hain.
Yes.
Okay. So today's my topic is which modality to be used: CT coronary calcium score, CT coronary, and conventional. We have kept the conventional coronary angiography at the last because majority time we are using and more than indicated way. So I will start my presentation with the CT coronary calcium. Can you see my slides?
Yes, sir. Yes, sir.
Yeah.
So the important nowadays, there are, as we know that India are the epidemics of the atherosclerosis. In 2002, Anand and Anand, who are originally from the Indians, now working in the America, he is predicted by 2025 to 2035, India will be the epidemics of the atherosclerosis. And we are also seeing the more and more younger patients for the atherosclerosis in the event. Recently, it has been linked with the COVID vaccine and all these things. But we are at the epidemic has been predicted scientifically in 2002. So coronary calcium score is validated measure for the subclinical atherosclerosis. It is an independent marker of risk for cardiac event, cardiac mortality, and all-cause mortality. To evaluate the coronary calcium score, we require the minimum radiation. So there is no radiation hazard involved in the CT coronary calcium score. It is less than the mammography, less than 1 millisecond. Pathogenetically, if we see the result, it is a result of smooth muscle cell apoptosis, begin with microscopic calcification, that is initially 0.5 to 15 micrometer, then grow in the larger cyst. So basically, it is a surrogate marker of the atherosclerosis. Just briefly, I tried. Hello?
Go ahead, sir.
Okay. Yes.
Yeah. Just
Sir, you are audible.
So briefly, I show you how the coronary calcium score has been calculated. There are the three different score, among which the Agatston score is the more widely acceptable. In Agatston score, what they do, they see the area and the density. If the suppose area is the 2 millimeter square and density they HU unit, Angston unit. So if it is between the 130 to 199, then 1 factor, 200 to 299, 2 factor. So area multiplied by density of calcium that lead to derive the coronary calcium score. Other than the Augustin volume score and density score, where though they are also applied in different trial, but routinely we discuss the Augustin score. So in subsequent slide, we focus on the CSU Augustin score only. So if there is a 0 calcium, then there no identified disease. 1 to 99 Augustin score mild disease, 100 to 399 moderate, and more than 400 is considered the severe. So who is having 0 score, very low risk for the future coronary event. Who are having the score between the 1 to 100, then the low risk of future, low probability of myocardial ischemia, 100 to 400, increased risk of future CV events, and more than 400, then the high risk for the myocardial ischemia. So if we apply to the clinical practice, how we can predict the CV outcome from the calcium score? So annual frequency of event in calcium score 0 is the 0.1 versus whoever the patient are having the calcium score between 1 to 100, the event rate will be the 0.5, and that event rate increase near 2 if calcium score more than 100. The why this calcium score require over and above available clinical risk factor? Because available clinical risk factor are having their own role. Suppose we take the Framingham score or SEVA score, they can predict the future CV event, but calcium score add on over and above this risk calculator. High negative predictive value means calcium score is 0, then surety is much more. The event rate, if we see the event rate is less than 0.5% at the 5 years. Highly sensitive for presence. If calcium score is positive, then someone will ask the chances of coronary blockage, then more than 50% angiographic stenosis, but only moderately specific if the age is more than 60 years. Means patients who are having the calcium score are there and less than 60 years of age, the chances of more than 50 narrowing is very much high. But if patient's age is more than 60, this prediction doesn't hold true. Calcium score at the incremental value used in addition to validated atherosclerosis cardiovascular. I will show you in next slide how we calculate the atherosclerosis risk score in a 155 years old male patient. An individual without risk factor. Suppose person do not have hypertension, do not have diabetes, he is a non-smoker, but calcium score is more than 400, makes the even though no risk factor, the higher event rate than individual with more than 3 risk factors. Suppose hypertension, diabetes, smoker, and 0 calcium score. So calcium score outweighs the conventional atherosclerosis risk factor in the evaluation. Patient having the typical angina, then there is no role of coronary calcium evaluation because typical coronary symptoms require the conventional angiography. So whenever the calcium score are positive, the prediction of more than 50% stenosis around 56%. So one can say if coronary calcium score positive, then chances of more than 50% coronary artery disease in about 50% of chances are there. So we have to add on the other atherosclerosis risk calculator or the trace test in the asymptomatic patient. Sensitivity to pick up the blockage is 98%, specificity less, negative predictive value very much high. Normal calcium score carries the high predictive negative. Positive calcium score doesn't always mean the blockage. We have to analyze in associated other risk factor. Suppose we coronary calcium score and test. The myocardial perfusion test consider the gold standard for the test. So patients who are having the 0 calcium score will have 7% of patient will have positive test, while the positive calcium score will have abnormal test in 13 to 15%. In patient with the 0 calcium score, the chances of ACS is merely 1%. So negative predictive value, as we see, the negative predictive value is much more. 0 calcium, chances of ACS around 1%. 0 calcium score, chances of significant stenosis is the very much less. What will be the calcium score and the diabetes? Presence of any degree of coronary calcium score in diabetes increase the risk and all-cause mortality. Calcium score less than 100, screening for the silent ischemia is not. So suppose patient is diabetes and calcium score less than 100, the screening further test TMT may not be required. But if more than 100 calcium score, patient should undergo the test to evaluate the inducible ischemia. Here we are talking the asymptomatic patient. Just patient appear the healthy individual who are carrying the risk factor for the atherosclerosis. And just I give the example the how to the online calculator available atherosclerosis cardiovascular risk estimated. So suppose I added the 55 years male, 50-year male Asian origin, blood pressure of 140, diastolic 84, total cholesterol 190, LDL cholesterol, HDL cholesterol is 38, LDL cholesterol is 120. I deny no history of diabetes, not smoker, hypertension, just taking the one tablet, not on statin, not on aspirin. Such kind of patient will have 9.1% CV atherosclerosis risk in subsequent 10 years. So this patient belong to intermediate risk category as per the ACS. So we should subject such kind of patient to the coronary calcium evaluation. So ACS scoring less than, if this ACS atherosclerosis risk calculator less than 5%, if it then low risk, 5 to 7.5%, borderline elevated risk, then 7.5 and more up to the 10%, that is the intermediate. So person asymptomatic ACV risk calculate risk fall between the 7 to 10% should undergo calcium score screening. So the intermediate screening score should undergo the calcium score screening. If this intermediate risk category patient already receiving the statin should not undergo, because the purpose of this calcium score to start the statin or not. The once patient already on statin, there is no added benefit of undergoing the coronary calcium score. Low risk patient with the diabetes should undergo coronary calcium evaluation. Low risk patient with the family history of premature CAD, sudden cardiac, then should undergo coronary calcium evaluation. Symptomatic patient, there is a no role. Symptomatic patient should undergo conventional angiography to get the final diagnosis. The coronary calcium score has been evaluated in the elderly population who are more than 75, LDL between the 70 to 180, and even elderly patient 0 calcium score carries the good negative predicted value. So the purpose, what is the purpose of, if a patient will tell I am asymptomatic, why you are subjecting me the whether to start the statin or not? By starting the statin, we can reduce the future CV event. The person who are having the intermediate risk category for the atherosclerosis risk category and a calcium score more than 100, we have to consider to start the statin therapy. Now, if patient in the high risk group, then statin and aspirins will helpful. So what are the take-home message from the coronary calcium score? It is coronary calcium score must be interpreted along with the other risk calculator. There are European calculator, American, now in Indian lipidology also come with our own Asian Indian calculator, how to calculate the atherosclerosis risk. The presence of coronary calcium implies the high coronary plaque burden, aggressive statin, but no further testing. Coronary calcium score in less than 40 years of age, less data available. But if patient having the premature CAD, younger and coronary calcium is present, then these are the patient for the high risk. One should consider starting the statin therapy. These graphs show the high. So if calcium score is 0, there is no benefit starting the statin therapy. If calcium score between the 1 to 100, still marginal benefit. But once the calcium score more than 100 and 400, there are significant benefit by starting the statin therapy. So the purpose of subjecting the patient for the coronary calcium score, most commonly nowadays people are more concerned whether we are having the coronary problem or not. Then we can assess by the atherosclerosis risk calculator in which category patient belong, either intermediate category or patient having diabetes. Subject the patient for the coronary calcium score. If coronary calcium score more than 100, statin should be started to achieve the LDL goal. If more than 400, then statin plus aspirin may help. When to do follow-up? Suppose patient on the statin therapy. Usually the follow-up not required, because once patient on statin therapy, if at all, then low risk category 5 to 7 years, and the intermediate risk category 3 to 5 years, one can do the repeat CT coronary calcium score. But one important thing, patients who are on statin, then the interpreting the coronary calcium score is the very much important, because previously calcified become more denser with the statin therapy. So increase in the calcium score in the same spot in the previous, then there is no bad prognosis. If with statin new development of calcium score, then it is the harmful. So the once patient on statin, same place, the calcium score increase, that doesn't carry any prognosis. So I believe that I have given the some insight regarding the coronary calcium score. Just briefly, I covered in few slides when CT coronary angiography will be helpful in the current practice. CT coronary as an alternative to invasive coronary angiography as an initial diagnostic test in patients with not having the CAD and chronic coronary syndrome, and test state is equivalent. When TMT is the equivalent of sloping artery changes, low workload, a patient develops symptoms in the low workload and EC doesn't show changes. In this scenario, we can subject the patient for the CT coronary angiogram, because invasive angiograph, there is arterial puncture, CT, there is a venous. That's why. Patient with the acute coronary syndrome and troponin ECG within normal limit, but patient complains of breast symptoms, difficult to differentiate. There are role of CT coronary where troponin is negative. Troponin is positive or LV dysfunction, then the convulsion angio only. Asymptomatic high atherosclerosis patient. In previously I have calculated, if patient are having the more than 20% risk category, asymptomatic, TMT equivocal or negative, then one can send the patient for the CT coronary to see whether silent stenosis are asymptomatic stenosis are there or not. In post bypass, usually in foreign, the bypass, whenever the bypass connection has been done, they put the one ring in the aorta or the ascending aorta from where the graft has been connected. Here in Indian, there is no practice. So while we are doing the conventional angio, we have to take the time to find the graft. While in CT, it will directly show whether graft is where located or not. So usually in our practice also, post-bypass patient having chronic stable angina, not ACS, we subject the first patient for the CT coronary and see how many graft are functioning, how many block. So whenever we plan for the conventional angio, we directly for the planning, this graft situated in this location. So we are having the idea. Post-stenting, post-PTCA patient having a persistent symptom and not similar of index event. At that time, for assurance of patient, we get the CT coronary angio. But important thing, the stent diameter is more than 3 millimeter, then CT evaluation is better. In more than a thinner stud. Now majority stent available is the thinner stud. Thinner stud means less than 100 micron stud thickness. The now available majority stent are thinner stud. But if stent diameter is more than 3 or more, then better evaluate with the CT coronary angiography. CT coronary angiography can be helpful and when patient undergo non-cardiac major surgery and the high atherosclerosis risk factor. Aortic dissection, when patient we are subjecting the patient to aortic dissection surgery, simultaneously CT coronary also helpful the coronary involved or not. Valve replacement, some center there are protocol they can okay with the conventional angio, some center are okay with the CT coronary angio after 4th-year valve replacement therapy. When the patient have to undergo redo bypass surgery, then the CVTS surgeon will get the CT coronary angiography precise location of the bypass because again they have to open up the sternum. If the graft immediately located functioning graft below the sternum, then the graft injury and the ischemia will be there. So they will subject the patient for the CT coronary angiography. When acute chest pain, there is a dilemma whether PE or dissection or ACS, then the CT coronary angio is a good modality. Coronary anomalies, then CT coronary is better because convulsion angio require the time and the operator's experience and expertise are much more necessary to pick up the coronary nerve. Sometimes right coronary arises from the left cusp, left coronary arises from right cusp. The operator experience is much more important. And nowadays, CT coronary angiography has been done along with the FFR. Usually, the CT scans could be more than 64 slices, then CT coronary possible. There are certain negative factors for the CT coronary angiography. This coronary artery calcification, obesity, arrhythmia, and patient motion. Radiation dose, it is between 6 to 12. If dual source and 120 slice, the lesser the dose. If 64 slice, the higher the dose. Much more double than the conventional angio. Image quality, it is a reconstructed image. It is not the live image. And temporal and spatial resolution are much less than the conventional angio. Motion artifact will be there. That's why you always reduce the heart rate around 60 to 70 with the beta blocker before the CT coronary angio. And we always ask the patient to hold the brace to prevent the motion artifact. This is the comparative chart. The spatial resolution invasive angiography is much more higher, 0.16. The still base CT only the 0.5 to 0.6. Contrast resolution better with the our invasive angiography compared to the CT and temporal resolution even with the best available CT scan. So the temporal resolution are not matchable to the conventional angio. The message is there when you are suspect, we have to find out the lesion, then the conventional is okay. If you are the high suspicion of a patient having the coronary, but we want to rule out the stenosis, then the CT will be the okay. So future, there are the future already the CT FFR, the CT angiography along with the physiological essence. These are the future of the cardiology. And transluminal attenuation gradient, they pick up the gradient across the lumen physiologically by CT. CT perfusion image, they combine the CT scan as well as the perfusion imaging, PET scanning, and the plaque trajectory. These are the future already there in the foreign market, will come in the Indian also. So we know the anatomically and physiological significance of the lesion. So these are the some trial. They compare the CT versus conventional. And finally, the conventional angiography gold standard. Every test has been STEMI, conventional, high risk ACS, intermediate high risk, the conventional, high risk stable angina, conventional, chronic coronary syndrome, where other tests are ambiguous result, then the conventional angiography. So I'm not going in detail into detail of the conventional angiography, but most important, the CT coronary calcium score is the preventive aspect. CT coronary between both invasive angiography versus preventive. In whole spectrum we can use, and the invasive conventional angiography is a gold standard. Whenever we are having the high possibility of the stenosis, the conventional is the gold standard for the angiography. in foreign, they are having the waiting list in the cath lab. That's why they have started the CT coronary in the lower interview. Here in our country, the cath lab are readily available. So that's why the CT coronary for diagnostic purpose is not well accepted. Thank you very much.
Thank you, Doctor. Thank you, Dr. Anand, for your delightful and enlightening presentation. We are very grateful to you for the preparation of such a wonderful presentation, and this topic of calcium was really, really good, your CAC. We would like to take any questions if anyone has them. You can go to reactions down at the bottom toolbar and just raise your hand electronically. If anybody has any question, please raise your hand electronically and we'll come back to you.
Sir, one question from me.
Yes, sir.
Atherosclerosis usually occurs in all the vessels other than coronary also. So we have a modality to know the calcium score and the CT angio for coronary. What about the cerebral vessels and the renal vessels and so? Is it useful for it also?
Yeah, definitely useful. But every test carries the advantage and disadvantage. The disadvantage is the radiation. So important, the coronary event is the life-threatening. The rest of the organ events are not a life-threatening. So that's why he focus on the CT coronary calcium rather than the other vessels.
But cerebral vessels also, they are causing a huge effect on the human life. Quality of life.
It is a more Tarun may join, but peripheral arterial disease not life-threatening. They may quality of life definitely going to affect by the peripheral arterial disease. There is no doubt. But this modality carries the radiation exposure. Cost-benefit ratio, how much information or you are getting by exposing the patient to radiation, how much benefit we are offering to them by subjecting the test. So any test carries their pre-test probability. That's why only the intermediate risk category patient of cardiovascular disease should undergo coronary calcium score. It is not that though we can subject. But peripheral arterial disease, there is no doubt.
Sir, peripheral arterial disease, non-invasive Doppler is a very good modality. For cardiac, Doppler cannot be done to pick up the blockage in the LAD or circumflex or the RCA. So for that matter, cardiac CT calcium scoring is a very preemptive test so that everybody doesn't want to go for an invasive angiography. And for peripheral vascular disease, carotid artery Doppler, peripheral artery Doppler, very easily you can pick up calcium, intimal medial thickness, fibrofatty plaque, and correlate with the symptomatology.
Yes, sir.
Okay, thank you. Thank you so much.
Dr. Anand,
yes, sir.
Do we prefer treadmill test or coronary calcium score as a pre-operative checkup?
Coronary
or routine health checkup?
Routine health. Preoperative and both I would like to give answer in separate concern. One is the routine health checkup. The routine health checkup, sir, as per mentioned, we have to apply the risk calculator score. If a person belong to the intermediate risk category, then definitely coronary calcium score add on and the atherosclerosis risk calculator. That is the one thing. We know that it is not the stenosis always. There is a plaque, there is lying plaque in your coronary, but it is harmful or stable. We cannot judge by the coronary calcium score. So functionality will be assessed by the, as you mentioned, the test will be helpful for the functionality. The test pre-operatively, either we do the exercise test or the dobutamine test will be the helpful. Suppose I will take the one scenario, patient having the coronary calcium score of 100 and dobutamine test is negative. Whether patient carry the high risk for the perioperative complication not. But suppose dobutamine test is negative, we have to focus on the dobutamine rather than the coronary calcium. What I believe.
One question to Dr. Madan, that in acute CV stroke, just for like thrombolytic therapy, we have a time frame. So do we have a time frame for interventions?
Similar timing is there, sir. For anterior stroke, we have 1 to 4 hours of time period, and posterior stroke, we have 4 to 6 hours of time period for basilar artery intervention.
One more question. Routinely, nowadays people are going for a health checkup, sonography, mammography and everything. So, for this, do you consider this carotid Doppler is mandatory? Should we make it mandatory for above 50 or 60? Should we recommend carotid Doppler?
Yes, sir, absolutely. Absolutely, sir. In patients who are especially smokers or tobacco chewers or diabetes, because they are at the risk of more atherosclerosis disease. But if the patient lipid profile is normal, echocardiography, ECG is normal, there is no need for sending them to carotid Doppler.
And
Any other questions?
Madhu, the coronary calcium, the Dr. Uday Jadhav also taken the lucid, but as per his suggestion, everybody should, but at least evidence-based, at least the intermediate risk category, the purpose of sending the patient for the CT coronary calcium to start the statin or not. That is the only, rather than the preparing for the angio should be. Patient is asymptomatic, intermediate risk category, TMT negative, then only the statin we can start as per the current evidence, what are having at present. And the patient belong to high risk category, and the aspirin may helpful, because we know that the aspirin failed to show the primary prevention benefit majority of trial till date. But higher calcium score more than 400, higher atherosclerosis risk, and the high coronary calcium, then aspirin statin will be the justifiable.
Any other questions from any of the audience?
I think if there are no questions, before vote of thanks, I would like to make two announcements. Our next CME will be on the 3rd or 4th of April, and subject will be announced later on. And one more hybrid physical this virtual CME we are going to organize on 19th May, that is World Family Physician Day. And probably at the Ahmedabad Medical Center, we are going to have a full mega family physician conclave from 9:30 to 1 p.m. This is the two announcement, and now vote of thanks by Dr. Smita.
Thank you, Dr. Jaswant, and my gratitude before we go to all of you. It was nice meeting both the speakers as well as everybody else, Dr. Desai, Dr. Vasant, Madam. Nice to see Hiren Bhai, Vinod Shah, Dr. Kusundra, and our two speakers were awesome. So before I take off, I'd like to request Ma'am Smita Ben to propose a vote of thanks. Smita Ben, over to you. I think she's frozen.
Good afternoon. All our staff, state brand speaker, Dr. Sir.
Hello.
I think Smita Ben is not audible. So
hello. Smita Ben, can you hear us? Can you unmute yourself? Yes. Try and come in again.
Yes. Now
yes.
I start again. Okay. It gives me a pleasure to deliver the words of thanks, this virtual webinar, to all the dignitaries here. Let me first of all start by giving the glory of the God for making the today's webinar success. On behalf of IMA College of GP Gujarat State Branch, I am Dr. Smita Shah, would like to thank our speaker Dr. Anand Shukla Sahib and Dr. Tarun Madan Sahib for sharing a knowledge with us. Very nice, informative lecture give us. I am also thanks Dr. Bharat Bhai, President of GSB IMA, Dr. Mehul Bhai, Secretary GSB IMA. Also thanks Dr. Darbar Sahib, Director of College of GP IMA. Also thanks Dr. Vasant Bhai, Secretary of the IMA. Also thanks Dr. Mahadev Bhai Desai. Thanks to everyone for the joining us today webinar. Thanks to all.
Thank you, Darbar sir, and the college.
Thank you.
Thank you, sir. Thank you.
So we conclude the session. Okay. Thank you.
Thank you very much, sir. Thanks for giving me this chance.